Yeah.
I think it is being recorded by the looks of it. Someone requested it for later viewing, and it looks like I can see the red record button is on there, as far as I can see.
Have you ever been up that tower, John?
Sweden? No, I never have.
Apparently it's really worth it.
I never know how, like, you have to in advance.
No, it's just sometimes you walk past and the door is open and then
Really?
you move at the bottom. And I always thought, oh, it's not worth that first thing up, but actually it's somebody so really, really worth it.
Okay.
It's absolutely lovely.
Yeah, I've seen people in it and wondered often how you can actually, you do so. I was quite pleased by chance that the Health Foundation logo matches beautifully the Smeaton's Tower colour scheme.
Yeah.
Yeah, I bet the view's lovely.
Yes.
Give it a few minutes. I don't know if we're getting anyone else. I have no clue. Is there anyone else with you, Caroline? Can't see him, afraid, because I'm in the presenter view.
Yeah, we've got 5 online.
Okay, I don't know how long I should wait for. I should give a few more minutes, see if anyone else. Is that all right? Just 1 or 2, then I'll crack on.
Yeah, sure.
Prolonged silence at the beginning of the recording.
Caroline, when you do the recording, can you top and tail it? Can you cut out all the chit chat at the beginning and just have the actual presentation?
Yeah.
Lovely, thank you.
Elevator music for the first 5 minutes for house.
Just chop all of this off.
All right.
You remember that.
I'll make a start if you want. It's going to be pretty informal, so just jump in if there's anything you want to ask. It's not going to be like a standing on eggshells or anything. I have no idea if this is anyone's had sight of what's been going on in Cornwall with this stuff or not, or okay, I'll do a bit more background. So basically, I suppose I'll ask a question. When I got asked to do this piece of work by Richard, I had no idea what a community health and wellbeing worker was. Has anyone come across the terminology up to now?
I've heard the terminology, but I would have had as much idea as you.
Yeah. Oh, so essentially, and I'll talk about some of this in a minute, it's a model that's community and public health facing that's been imported from Brazil as an alternative to social prescribing that has some of the facets of social prescribing, but also things that definitely doesn't have to reach people in a different group, basically. I'll go into it. Ian, do you want to come over? Save you dodging. Yeah, no, it's fine. Come in. Bring your muffin. We'll be all right.
Share muffin.
And It's been piloted elsewhere, which I'll show in a minute, but it got introduced into Cornwall, and the Health Foundation had a fund that was, I can't remember the exact title, it's something like Accelerating Innovation. So they funded the pilot for this piece of work, where that project allowed the NHS through committee to pick several innovations to throw at the health service and see what it did. Things that are a bit more unusual for trialing. One of the things they picked was, rather than a piece of technology, they picked a community-based health worker model to trial, and that's basically what I'm going to talk about. I did a very qualitative piece of work and just the findings. So this is, again, for the proper introduction. The model was designed in Brazil to, for want of a better word, think about how can we help the people who live in shanty housing, favelas, etc., access healthcare. We can't just expect them just to turn up to the primary care services, or they'll turn up at A&E when they've got problems. So it was an attempt to go out physically to the places of identified deprivation and then engage people in that role. I'll show you some more of the other places in a minute, but it had what it describes as a model as 3 unique things. So universality, so all households, it's very much a household approach. They'll work with literally anyone. The mandate is basically not to focus on a specific condition or a particular target. The only kind of focus is geographical. Equally, it's any and all, so it's what they call cohesive. Children, adults, teenagers, literally catch all. You go to a household in a identified deprived area, engage the people, see what they might need. But equally, they call it integrated as a model as well. So these people don't work in parallel. They'll be in a primary care team. They'll be in a voluntary sector. They're meant to be going anywhere and across boundaries, basically. I'm just going to keep calling it CHWWs for the purpose of not repeating the terminology. So this is to put something visual, this is from a paper from Matt Harris, who is a Thames ARC employee, as it turns out, who's been leading this for years. He works in another ARC, but in London. I think it's the North Thames ARC, I should remember. He's basically been the leading light in getting it into the country, and has been, he's got some PhD students who work in the area too, who are very good at it. So it's one of the interesting things about the project is there is scope for going forward if there's inter-ARC collaboration on the idea. So basically, as just said on the previous slide, they work across professions, across children, antenatal, social care, anything that you could think of to prescribe to, but they work in these kind of micro area of identified using, in this country, it was local deprivation data that you'd honed in on. And there were 4 to 5 sites in Cornwall, 4 areas, 5 sites that this was rolled out across. That I was looking at, if it wants to move, it wants to switch slide. Come on, there we go. So, but it's not just Cornwall and the Isles of Scilly that's happened in. To give you an idea of the scope, it's in all these other places as well. So we've got the southwest, north. There's quite a lot of it that's happened around London, Oxford. One of the big studies and a lot of reporting came out of Kensington and Chelsea, Calderdale again in the north, and Bridgewater. So if I can, there we go. I'll pick up the ICS map. So whilst to me it was quite new, as it turned out, there'd been a lot of years of back work of, as you can see, my fantastic graphic design skills have come into play to show you that it's been all across England, and there's one trial site in Wales. Some of these have been going, like the ones in London have been going for a number of years. Others are like Bridgewater and Somerset is just having like the beginning stages of it. So it's more comprehensive than I realised. So coming actually to the pilot work rather than the topic, it was basically a piece of co-design work that I did with the NHPC. Have been leading a lot of these sites, so they actually have like a community of practice from all those places across the country, where every quarter I believe people come together to talk about it, and I use some of their other pilot evaluation reports to design the methods. It was literally because in Cornwall there were 10 people recruited to this role to try across 4 sites, 4 locations of 5 sites. I literally just interviewed every single one of the 10 participants, their managers, and some of the other supporting staff on the project. And it was very much a project that was related to the setup and running and scaling. So they wanted to know it was pilot work, not like clinical outcomes or effect on the patient. It was designed to be baseline for a future evaluation, talking about implementation and the setup, because of this is still kind of nascent as an idea. How would you do it if you scaled up from one area? The work in Cornwall was one integrated care area. So Cornwall has, I think, central, west, north and east. All of the sites are in the central integrated care area. Again, so what I'm going to talk to you about basically is how it was delivered and how it can be scaled. So there you go. The actual introduction of these people was split across Newquay, St Austell, Truro, Falmouth. And the idea of this was that they'd have slightly different configurations. So some of these people worked almost embedded in a PCN, closely to primary care teams, but all of them were voluntary sector employees. So they went to the local, probably one of the most prevalent voluntary sector providers, who would host the community workers, who then also would have colleagues in the NHS. And some of them had things like, I'll come to it in a minute, like monthly meetings with them, others would just ring them on the phone. One site had that literally embedded in a PCN. But the idea being to kind of figure out where the boundary is between the voluntary sector and the NHS for delivering these type of things, and if any differences popped out about it. I won't go through too much of this, really. I want to say it's just I sampled everyone to try and make it in some kind of qualitative representative sense, as well as the people involved in the training and the setup, because it was very much a pilot focus. So I've got a few more slides, mainly to chat through the themes, check I'm not waffling too much. Okay, I've got plenty of time to kind of go through what came out of it, because it's a relatively novel space, I suppose. And in Cornwall, outside of the social prescribing work, one of the trainers very kindly told me that they've got other sort of hybrid roles that are somewhere in between this position and social prescribers, and they're still feeling out how far into the community and actually knocking on people's doors do you want to go versus how much do you want to wait for people to enter the system and then refer them appropriately for it. And they're not quite entirely sure, but this is one of the pilots to see where it might sit in that location.
Before you go on to the findings, could I just ask a bit more about background? I
Yeah.
saw that you said that they went to every house.
Mm-hmm.
How did they make the decision? What's the logistics of that actually happening?
Yeah. So after they've been recruited, they had access to the deprivation data, and they would literally have maps with street boundaries that they'd have, like, here's my defined area, here's this, typically it might be in the poorest bit of Newquay or Falmouth. And then the strategy of going around houses had a lot of thinking about it. Actually, I haven't covered this, but I can talk about how my uniform do I wear? Do I wear do I present myself as being associated with the NHS or not? Do I wear because some of the charities were things like, they'd run like horticultural programs and people knew the name and associated it with like gardening or like, the apple centre that you might go to buy your grown veg or whatever. The door knocking process started with a lot of leafleting. So they had like badge leafleting and flyers that they'd go out to put around to kind of generate interest. And then I don't know how strategic it was by picking like streets, but they'd also, within your designated area, where the coffee mornings are in the church, where the community assets and the events are. Mm-hmm. So I think they start to cluster activities around that.
What were they offering? I know you did that.
Yeah.
What was it? They knocked on the door, they then say.
This was another really interesting bit. They realised that you needed like a spiel, like your Anglian windows or something, to get over the threshold of it being slightly cold calling, and how to talk to people and how to interact with them. A lot of it, and I'll come on to this point later, was initially trust building. The other sites that I showed on that map would indicate from the reports that it would take 6 months to get any kind of like actual engagement from some of the families, because you just needed to build the rapport. It was definitely not because these are the people who are either refuse to go to the health service or can't access it for one other reason and need a lot of relationship building. So when you get in, you're building the trust, and then once you build that trust, you're effectively trying to identify the patient unmet need, and then helping them like by sitting down sometimes in their house or in the coffee morning and telling them where to go in the system, how to access. Yeah, exactly. But the idea being that can be hospital, primary care, voluntary sector, social, it can be the debt advice clinic. That's where the kind of social prescribing bit comes in. But a lot of the role was based on the idea that kind of social prescribing step is like the peak of all of the engagement work to get up to the point of someone that might be terrified of doctors and had terrible experiences, to get them to the point to send them somewhere.
Just one important point there. I'm working with
their lead commissioner in Cornwall, and Alison, who's their lead doctor. And the biggest problem they have is what is okay identifying is actually coming up with the goods once you identify it.
Yeah.
Because like everything, everybody's got waiting lists, etc., etc. So sometimes, and I don't know if this project is losing its sort of I don't know, credibility, because you can take it so far, but you can't take it into that next phase.
Yeah, no, I agree. And there was a lot of interconnected work with all the other services that they could push people to know where the bottlenecks might be. But I was, again, talking to people in Peninsula Social Dental Enterprise yesterday about the fact that they've almost not got access to the people, the dentist waiting list. So there's no point sending them to an NHS dentist because they'll sit in a list for everything. So communication and interaction was really important, and I'll talk to that in a moment. One of the things I found was really interesting from like an implementation science point of view is this project actually worked really well, and it's actually been scaled and it's gone to other integrated care areas in Cornwall. But one of the things that made it work quite beautifully was the introduction of social prescribers in 2018. It kind of laid like a net of training and access systems that they could just scaffold onto. So it turns out when you want to introduce some of these new roles, if you had a good something similar like social prescribing as a national program, you can overlay some of the structures to reduce the time frame that you might do to getting these people up and running and going, and that really jumped out. So for example, they had overlapping meeting schedules. Some of the voluntary sectors obviously would have social prescribers and they put them in the same team, same meeting rooms. They ended up having the same trainer. So that was a really good thing that in Cornwall, the kind of person who was overseeing the social prescribers in the voluntary sector's training needs, which was one organisation, took on the role of training these people as well. So they could coordinate the effort to not make it duplicative, because that was the other problem, that it's a new thing in the system. How do you make sure that they're not just seeing the same people offering the same thing? So it had a really nice way to kind of direct people without losing that. But the connection was really important to stop that kind of stuff in, and all the intel from the social prescribers then got fed to them, and vice versa as a kind of nice way to exchange information. So yeah, unison to deliver services, it turned out to be really quite important, and that seemed to work well. But it did vary. I definitely found that whilst this is a model, like I said, some people sat in an office with the social prescribers and had scheduled meetings. Other people would just bring them up once a month if they needed to talk. And it very much seemed that each locality and the kind of necessities of place-based care seem to dictate what the relationship would be. And it's very hard to specify in advance how they work with the other kind of prescribing teams without it not really functioning. A seaside town with lots of tourists, to call it that, had lots of different pressures in it than if it was in St Austell, for example, and that relationship changed. But it definitely seemed that a lot of this pre-work really helped like the implementation, and I tried to link this to as many real-world things as possible. The commissioning and the expansion of it always comes up against the kind of commissioning senior executive people asking where the outputs are for this. You've been doing it for 9 months. What tangible benefits are happening? And this program got off the ground a lot quicker than some of the other ones, and they were still asking, we want to see returns. But comparatively, I think scaffolding off things like social prescribing, training, offices, structures, network meetings helped them get up and going a lot quicker, and they got more of the kind of executive buy-in that they needed to then actually consequently get some funding to scale it up. That seemed to be actually critical in a way.
Can I just ask what the difference is between a social prescriber and a community mental health worker?
Yeah, sure. So,
sorry, because I think some social prescribers are linked into primary care.
Yes.
And those already employed by the voluntary sector, like these guys.
Mm-hmm. I think
so that's
I will take other people's opinion too. I won't be this funny Karen to be here. Some of them will have very specific bounded roles about the age groups that are working with, or the diseases or the conditions that they're working with. Equally, they might have some more organisational boundaries. There are lots of similarities, but a lot of them won't do door knocking, I think is what it kind of boils down to. And I don't think it's like an aversion, it's just that they've got a remit that doesn't always involve like in-depth community work or sitting in, you know, I don't know what it might be, like a knitting group or what have you. It's not exclusively community focused, and some of them will have no community work. It is a bit of a catch-all term, and you'll find that there's like a typology of social prescribing and it works differently. So like if you're in the Mind mental health service, your social prescribing affiliation won't deviate into like completely physical related stuff, for example. And these people were meant to have that. The difference really is like the universality, I suppose, rather than the specificness that sometimes can come with social prescribing.
What's it cost for one of those?
The pro rata payment,
Or person?
they put it at a non-clinical pay grade because it was determined that the ability to establish relationships with people was more important than deeming it to have like a clinical knowledge base. I think the payment was not I don't know if it was a band down from social prescribers. It might have been one band down, I think, to start with. I think NHS entry for social prescribers is band 6.
Social prescriber.
Is it? Yeah.
How much is that a year?
It was a little bit lower because you didn't.
£5,000, 30. Well, it depends who too. But to that, as a salary, it's about 30k.
I think from the public available job adverts, it was a little bit lower because they didn't have to have a clinical qualification, basically. So just under social prescribing.
Social prescribing technically is a non-clinical role. So, but yeah, it's band 6 on the governance.
The other
The reason
thing.
I asked the question is that I'm working with Cornwall, so they've got 220 town and parish councils. Town and parish councils now under the new law, but you were a council, weren't you?
I was
Whereabouts?
I was in Campbell and King.
Right, okay, so we've been talking to all of them. I mean, the first question I got when I got to Cornwall is, why are you coming down here? You're in college. It really was like that. What do you bring? So what I'm trying to get round to is that there are 220. They have a responsibility for their communities.
Yeah.
And that isn't much, 300k. I know I'm talking about precept here, but what's your thoughts on employing those into the town and parish council?
It's not out of the bounds of possibility. I mean, all of these people were in voluntary sector organisations. It could be within a local authority as a mechanism of doing it. I don't think. How can I put it? I'll talk about the finance bit in a minute. What they really needed, and it was felt by the interviews, was some kind of stability to make sure. I'll go on to it in a minute. There's a trade-off between where they sit and the kind of culture and ability to roll things out versus the regulation. Maybe we'll jump to that point in a minute, and I won't go over it again. Some of the interviewees suggested it was great to have them in the voluntary sector because there isn't necessarily the barriers and the regulations to going out and like Mrs. Jones needs a new washing line because she's drying all of her clothes inside her house. It's giving it mold inside the house and it's damp and that's affecting her breathing. The fix she might need might be a £3.50 washing line from Wilkinson's. But the problem was then, okay, so how do I sign that off from the internal like NHS spend? And the voluntary sector said we could just go and buy it, and it's not we've got less of these steps to doing things. The counterpoint to that was always the voluntary sector funding model is more vulnerable than something like the general medical contract. Like the NHS should always be there, and you put them in the NHS. It takes longer to set up the roles. It took longer for them to get access to the patient record system and all the other stuff. But voluntary sector organisations have a bad tendency of contracting if they lose money or falling over completely. So there was this ongoing debate about how to do this, about the speed of doing things versus the stability of like long-term placement. So maybe a local parish council, town council may not be a bad one because it's got stability. They're always going to be there.
They're chomping at the bit to do it.
I wouldn't be surprised if it'd be another way to skin the same cat, really.
Okay.
But yeah, it was a debate that no one had there are pros and cons to both, depending what the finance model is, really. Again, NHS relationship varied from sites. I've said that really. There was more or less integration, which I just talked about. So again, getting into the NHS systems as a voluntary sector employee takes a bit of bureaucracy sometimes to overcome, but it does in the long run. The argument being from the interview's sake, allow you access to things like public health data and better planning for access and et cetera, et cetera. It does slow the scaling though. So if you wanted to get this off the ground quickly, which I mentioned earlier, it sort of gets the commissioner buy-in. Starting with the NHS is a sort of weird, a difficult way to do it, because it will slow you down when you need to be getting the buy-in from the senior staff to scale it. So the argument was the voluntary sector is a great way to start to scale and implement things. From all the conversations and the different setups that I had, it didn't really seem that there was any kind of one winning group. It very much seemed that there are just different ways to do things in different places, and maybe in the future, after the pilot work, in the long term, you might be able to tell which one it worked better in some way, depending if you want to look at like the wellbeing scores of the participants and the patient outcomes. Equally, working with the NHS had the universal pressures that it has as a system, but equally, local sites had real particular things that you have to be considered as well. So integrating someone in a PCN in a area that's got a lot of pressure on it, or seasonal tourism pressure, was quite difficult, for example. And the relationships were better in some places than others, depending on what the primary care setup was like. Okay, so the other bit that I looked at was how to scale this, really, and what were the really key factors, so the kind of takeaway points of how to scale the pilot. It turned out the training manager was really actually sort of sitting at a linchpin, because there was someone in this oversight role who was looking at the social prescribers and helping with the training, the community health and wellbeing workers, and all the other trials for different types of role, who was in this beautiful position of knowing what they know, doing their training needs and directing them. So it really helped to have someone who had like oversight of everything, which is a little bit tricky when you've got separate voluntary sector organisations and different PCNs together. But as it turned out, for this structure of this pilot, it was the lead trainer who saw over everything and was really able to make people work together rather than duplicate the effort. One last thing that's kind of come out that I thought was really interesting was, again, for scaling these things, one of the voluntary sector partners talked to me about the costing model needing to change for implementation. So for the implementation science bit of it, he was saying the voluntary sector partner has like things like a limit on space. You can't just give us more money and when we run out of office space, or equally said, you know, staff capacity doesn't scale in a linear fashion. So when it moves into NHS delivery, you have to pay for it differently than when you're piloting it. And he said the problem they always have is people just think, well, we'll just add the same costs on another area. And then you find out you've run out of space, staff capacity, time, emotional, you know, resilience, etc. So his argument was voluntary sector scaling needs to have like its own kind of finance model that's not the same as piloting, which I thought was a good point and why things might fall over.
Just on that point, that's something we found social prescribing, and we came back strongly from the voluntary sector, and we lobbied NHS England to get extra money to do that, because they factored in the extra management costs of employing the voluntary sector.
Yeah.
For those very reasons, like the supervision, the management, which all have a cost, and we're just thinking about the individual.
Yeah.
It's just a classic way of thinking about the voluntary sector, you know, not really thinking about it as how to resource it properly, as you would say.
Yeah.
More strategically. I
think it's the gentleman in question had seen a lot of things pilot look good and then fail implementation because of the finance model more than anything else. The good thing about this was there was a real healthy appetite for recruitment. So it could be scaled because there was lots of people for the vacancies, which is good. Unknowns tend to be that there wasn't any really rural areas. So how you direct people when you're in the Lizard Peninsula is more of a confusing thing than if you're in a kind of like area near a big town, basically. So there's still some unknowns for it, although what it's like in northwest England would help inform that, like in transport and other things that was difficult. The other bit about it is, as I've said about 2 or 3 times now, evidencing the things that you're doing in the setup phase, like earning trust, is actually pretty tricky to prove to people who are in a job that deal with annual returns for finance. But it was essential. And it was sort of like you were left with things like counting the number of interactions, and the interaction could be, to give an example, intervening in an attempted suicide, or interaction could be signposting to the park run, but each had one bean count that you're passing over to the evidence. So that stuff was tricky. I thought it might be around, there you go, on half an hour if my watch hasn't stopped. So that was really it. It was just a small thing to say that it scaled up, and the last little bits are we're looking for ways to keep working with them because I really enjoyed working with the staff. One of the kind of knowledge exchange bits that came out with it was I discovered the quality improvement team in Tredinnick-Rowe Royal Cornwall Hospital Trust hadn't had any existing relationships with the university that they maintained. So, and it seemed like a really useful connection to keep working with. So I'm bumming around for funding to keep doing more work with them. They've got a little bit of money for two associate clinical research fellows in public health in Cornwall Council that they're doing a longitudinal evaluation with, but there's no more for me. That's the kind of end of it.
Are they doing more? Did you say they're doing more sort of longitude? Are they going to look at clinical data?
Yeah, exactly. They're working with a company that's tracking all the referral data and the where people go in the system to look at that, and they're using various things. Like there was a lot of discussion about wellbeing scores and which ones to use and how you can pull clinical data out the GP record and if they're in it to track. So there is some long-going evaluation, but I'm not. This project is kind of terminated and just being written up really at this point.
Well, there's a similar project about to kick off in Plymouth.
Oh, was there?
So yeah,
That's
we're
interesting.
kind of interested from the HDLC might be involved in it actually.
No, it's
In the other practice, sort of the deep end practices are got some money to run a similar thing.
Oh, okay. Well, that's
So we're
interesting.
going to be involved in evaluating it, but which gets me thinking more broadly. We're quite, because we could link that with the one data set and do some stuff around that. But the problem is, I think, well, they've done like analysis of social prescribing, and they show that you find lots of unmet need. It's not a picture that clinicians want to hear, because actually people start using the services more, and potentially in like a year or two's time, depending on what happens in the economy and whether there's what else, it might go down. But clearly meeting a lot of need out there. But that's quite complicated to do. I suppose that's why I was super interested, whether we can sort of link and
The NAPC group might be useful to look at as well as coordinating it across the whole country. There's loads of white papers and things they've written. It's really interesting. So yeah, there's there's a wealth of stuff, like I said at the beginning, that I didn't know about and wandered into quite happily. So yeah.
It'd be good to feed your lessons into Plymouth, actually.
Yeah, I'd be very happy to talk to people. And again, before I take any other questions, I'm looking at the only idea I had, waffling a little bit, is that the Exeter Health, Lynn already knows this, and I've forgotten the acronym. HMSA, Health Services Modelling Associate course, allows you to look at referral data and do some, I would love to know where they go in the system once they're in it. That's the next idea, if I can apply to that, to actually model and visualise what happens to people when they've been through in connection with the community health and wellbeing workers.
The challenge there is the tracking in the voluntary sector.
Yeah.
In Devon, we have the potential opportunity with Joy app.
Yeah,
to do
that's
that.
what they're using.
So that, and if we could bring the Joy app and the Devon data set together, that would be really interesting, which I'd love to do.
Yeah.
So we should
I'm
chat about that, but
I'm talking to one of their employees tomorrow afternoon.
who's that, Rob?
Enjoy to explore the technical possibilities of what's actually possible for.
Where are they based?
I really don't know off the top of my head.
This is an app that's used in general practice now. That's a very quick and easy way to refer someone to social prescribing, but also pensions and things. It draws in a lot of data that kind of stuff very quickly, and then you just have your own bit.
So one of the things that came up is what we did in Devon was for the Devon to buy the Joy app to commission that piece of work across Devon. And I don't know how much it's being used, but certainly I've never really looked at actually what the data's like, but I'd love to. But I've got sort of connections with some of the people in the Joy app
great.
as well. But,
Sounds ideal.
I've forgotten his name now. I'll search it out. I did another piece of work. He was looking at doing a social prescribing piece. I started a little bit of work with him last year. But yeah, no, I think it's a really fascinating model. And I suppose there's a bit of debate then in Plymouth about the type of model they were going to have as well, whether they're going to have something based more in clinical practice and having a slightly more clinical or sort of very kind of social prescribing. And there's that sort of big public health space in the middle which is like, if you're a bit more integrated, you can start to look at they've done screening, vaccinations and that kind of stuff, that more kind of preventative stuff, as well as like, because I suspect a lot of it's going to be around cost of living crisis, a lot's going to be health inequalities and mental health.
Yes.
Rather than, I don't know, it'd be intriguing to know what sort of people they found. How did you look at that?
They the, how could I put it, thematic interactions where people were sent are recorded in a sheet as well as Joy. I can't remember off the top of my head what the kind of prevalent themes are, other than I'll say one thing and then I might see. Donna, I'll forewarn you. I don't know if you can hear me. You're welcome to come in and add anything if I missed anything. One of the participants very nicely said, because I was asking in a focus group about, you know, what do you think the repeat themes are that you're seeing? And they said to me, we're seeing, you know, some areas might have more of a concern for suicide, some might have a concern with finance and the rest of it. One of the employees said, it's just deprivation that's like the whack-a-mole that pops up in a different area. And in Newquay it might be debt advice, and in St Austin it might be suicide, but it's quite literally just the deprivation manifesting in a local area in a different way. There isn't really like an underlying difference, it's just, it pops up and that how it does in whatever. Falmouth with students might be something else, you know. So it is tracked. I can't remember what it is off the top of my head.
Can I invite you to the next meeting with John, with Stuart and Alison?
Yeah, if you want
and Kellock.
Oh yes, of course. That's exactly the. I still have some of the books they published about the Good Counsellor Guide. I think it was.
Yeah, that's right. It's just that they're looking to expand their remit.
I'd be very happy to. Is there anyone online that wants to ask questions whilst we're chatting? I don't want to disenfranchise you, or if not, it's okay. Right.
Can I ask the question
Of course.
while the online people are unmuting themselves? You said you were writing this up now, John. Do you think you'll be able to publish it so that it gets wider attention?
I'm hoping so, and I've been a bit slow about it. Through my complete blind luck, BMC Public Health, I think, has a special issue about community health and wellbeing workers coming out in a couple of months with the deadline of it. So through nothing other than Donna, very kindly, and other people who's on the call signposting me to it, it appears to be topical enough that there's a journal with a special issue. So I'm just going to, the report is pretty much there, but the report, of course, is like 17 pages and it needs to be cut down. So I'm just going to go where the special issue is, I think, more.
Yeah,
Makes sense.
And it's on the fee waiver list for the university's journals, which makes it happier, so I don't have to worry about paying for anything.
An interesting comment about the urban versus rural, how this would work, because you can see in an urban setting you get deprived areas and deprivation, and it's an area-based categorisation anyway, so it could mean half the population is very affluent, half is not. You know, that could be an average, or you could, you know, so you get a lot of hidden deprivation in sort of average areas, don't you, as well? And so I think in rural areas, the patch is going to be huge, and then how do you kind of, where are the kind of meeting places or places do you go around and knock on people's doors and how?
That was exactly part of the trial and error bit, that they discovered door knocking has a sort of limited return up to a point. One of the nice bits of feedback was about how the weather affects this kind of stuff, and particularly today's a good example, knocking on people's door in the rains yielded almost no interaction whatsoever. They very much discovered on a day like this, you want to find where the community centre is and go and sit in it and be sort of like triaging on the desk or whatever, or interacting with people there, because no one wants to talk to you. Conversely, in the sunshine, door knocking perfect, and you get a lot of people who are in the gardens, and you can have a conversation starter about their plants or the weather. So like you have like weather determined community engagement methods that seem to, you know, things that I didn't think in advance would have a bearing on the success of getting involved with people. But there was a lot of trial and error to like hone the technique, you know.
It's highly critical. A document came out of the government about 2 months ago about Cornwall, Devon, Somerset and Dorset about their rural support and services. There's some really good data in there, because rural communities tend to have a high percentage of older people.
Yeah.
Really high. Like, you'll find that with your work. And also engaging. And I'm amazed, and you'll know this better than me in Cornwall, but the amount of community-based rural support services that are available don't get engaged, like Rabbi, Community Services Network. All these are there, but somehow they get missed by the statutory agencies.
Or they're not formal, like, I don't know, the amount of like therapy that happened at the Mole Valley farmers for all the local farmers who to go live was ridiculous. It was just like chatting shop, basically.
A community farming network, young farmers, etc.
Yeah, it's at its infancy in a way to figure out how to do it, I think, and there isn't. It's very much in the kind of place-based stuff. You know, it seems to be very within small geographical areas.
John, as the pilot is over, does that mean that the community workers aren't in post at the moment, or are they still working?
They're still there and still expanding. They've definitely gone into the West Integrated Care area in the sort of Penzance area, and they're in, I keep forgetting if it's North or East Cornwall. So they started with 10, and I think they're up to 16 now. So basically the pilot worked well enough that they were able to make a business case for extra funding, and it's gone from, well, there's still pilot money, but I think the NHS is also funding some of these positions as well. So they're trying to do it almost county-wide, and it's an evolving thing. But again, the part of the reason of making this about setup was, if you don't know where the voluntary sector provider is out in Bude, you need to pick the reliable person that's going to last and is not going to fold and has all those community ties. And I don't think I haven't said, and I've probably talked too long about it. Edmund, one of the good things, one of the sites was about the GP relationship, and it was commented having a really active, engaged GP. That one of the sites had GP that would just turn up to the voluntary sector community area and try and find the manager and be like, I want to work with you. And that was like the best way to do it, because they already had those structures to kind of step off. But you need to find that in North Cornwall and East Cornwall, and it's a bit of a gamble to know who to go with. And obviously voluntary sector is very competitive for funding. I'm sure more than one person organisation might want it in one place. So I'm sure there's the usual wrangling that probably has to be involved with this kind of stuff. But
is there links with your work and Sheena and that work they're doing with coastal communities?
No, there isn't. I don't think I've talked to Sheena or anyone about in this at all.
I mean, it's a national one, but then Cornwall's got urban, rural isolated, and coastal.
Yep.
So you've got all those individual communities. So I know they're looking at that. That's quite interesting. Is it Charles who sits in the office there? He's part of there as well.
Yeah. I suppose the other distinction here is how they differ from like community builders as well.
Yeah.
Because there's sort of community builders over here, you've got social prescribers here, and so again, they're sort of somewhere floating around, doing a bit of probably functions there. I don't know if they were doing more proactive kind of community building stuff, like responding to needs, or
I'm not sure. That role got mentioned, but I don't think it was everywhere in the pilot sites. This was one of the things about finding the place for it. So the voluntary sector actually got another fund for a different role that I can't remember the name of, but it was part NHS funded to train their receptionists to do triaging. So that was like another step. So not in the community, but when they came in the community hub, for example. And there was quite a few of these. I found 2 that I never heard of that are like pilot mini trials of someone had 100 grand to work with the voluntary sector to make these little roles to send people places. But it's still not de facto I was going to try and make some kind of organogram to think about it, but I never got there yet to think about how it all sits together.
Rather than the person in the way, there are lots of different functions, aren't they, with connecting people to it's not just connecting, it's as you said, it's the building trust. And that's why you need a long-term sustainable approach to this, I would have thought.
Yeah, and I don't know quite how all the tendrils go out to other places like the social workers and the rest of it, but I think there is a mechanism. I'm just not aware of what it is.
I just wish all these different workers in any community we had a system, same as air traffic control. You could just watch all these people walking around Cornwall. Mind you, they're not
Yeah.
there we go.
Well, I mean, I guess there is a way about how you, whether you just take an area approach, go out, knock on people's doors or go to community assets to supply, or whether you more strategically target people that are the practice in certain areas. So you use the, the area and the practice database maybe to target people.
Yeah, it
Was
becomes,
anybody doing that?
no, because the focus was definitely like the people that wouldn't get in the door, I think, and then to build up the trust to do it. That was, I think that was the idea of like, if it's uniqueness, it was the people that are don't know, too scared, or even other things. You know, some of the conversations I had with providers where like the economy's got worse, and there are people who need to access voluntary services, but they don't feel like I'm the type of person that goes to the community centre for, or the food bank, and a lot of the work they had to do was like this new group of people who are, I don't know what the right word would be, more poor than they had been and didn't need these services to guide them to it. So there was that kind of element to it as well, as rather than being in the list or the system.
Yeah. Just think about who gets referred to social prescribing. A lot of it will come through the GP, not all of it.
Yeah.
Some of the voluntary sector do. There are also people can self-refer, but it requires you to know about it and kind of feel, as you say, Phil, this is what you need.
Yeah, a lot of the people I think ended up having quite complex cases that they ended up meeting.
Mm.
Oh, there we go. There we go. Come on. What was it saying? Lots of parallels with some of the conversations in South Brent. Thank you. I've missed all of these. They haven't popped up just now. Sorry about that. I do apologise. Roles work across mental, yeah, they're all across mental and physical health. Yeah, the budget. I'm not going to say anything about budgets. I think that's about it. Sorry, the questions are actually incredibly slow to come up on my Teams. Apologies for that.
How do they introduce themselves? What title do they use?
I don't even know how it's done because it changed between areas. That'd be an interesting part because they played around with it and they actually had like a door knocking training exercise with like, almost like putting a fake door and how you handle people. I know they started off with like, in the beginning, I believe they were introducing themselves as part of an organisation like the voluntary sector one. I don't know if that continues or not. I think in some areas it did. But part of the long story short was the providers, NHS and voluntary sector, like I said, could be associated with things that were not health related, or in some areas the NHS had a difficult relationship because some of the GP practices were closed and the locals were annoyed about it, and they shied away from association with the kind of those places. So they had to tweak it depending on local sensibilities.
Yeah.
I don't know what the exact speech is, but I'm fairly certain that they got it down to some kind of art form of finding the right words to say to people to get their attention. Again, some people wear uniforms, some people wear badges, and some people decided that didn't work at all and they were more plain clothes.
I remember introducing myself years ago as an adult worker, and this lady said, I don't want any of that mucky stuff. There we go.
I think, John, you illustrated some really interesting points that you'd be glad to see some of the quotes that illustrate those points as well.
Yeah, I've been a bit slow about it. The report rather than the paper on it. I think might go on the NAPC website, the kind of bigger, that's less about the methods and more about the data.
Yeah.
That they were having a website revamp and it had to wait. So I'm hoping to get something on there somewhere.
And are you presenting it? Was it at SAPC?
Pardon me?
Presenting in Cardiff?
Oh yes. So this is what my poster presentation at the SAPC conference in Cardiff. So I'll be standing in front of a piece of paper with similar content on it next month.
Thank you.
That's all right. All right. Thank you, everybody online. I'm going to wrap it up now. I appreciate the comments and the time and everything. And please email me if there's anything else that's useful or I can help with or what have you. Bye, Jane.
Thanks, John.
Bye, Karen. Bye, Stuart.